Good morning, ladies and gentlemen, and welcome to the presidential lectures. Just a few introductory comments. First of all, let me introduce my co-chairs, Günter Deutschel, the past president of the International Parkinson's Movement Disorder Society, and Oskar Gershanik, the president-elect. Let me remind you of what you've heard many times before. Please silence your cell phones, and photography is not allowed. Faculty disclosure information has been shown on the rotating slides, and there will not be questions and answers for this session. This is one of the signature events of the Society, and it's always a pleasure to recognize both junior members who have made outstanding contributions, and of course some of our most esteemed and respected colleagues. We're going to start with the Stanley Fahn Lecture. The Stan Fahn Lecture was created to recognize an outstanding scholar and role model clinician in the field of movement disorders, and our co-founder, along with David Marsden. The awardee this year is Dr. Joe Jankovic. Dr. Jankovic is Professor of Neurology and Distinguished Chair in Movement Disorders, Director of the Parkinson's Disease Center and Movement Disorders Clinic at the Department of Neurology at Baylor College of Medicine. Dr. Jankovic was the third president of the International Parkinson and Movement Disorder Society after Dr. Fahn and Marsden. He's the recipient of numerous honors, and since 1991, many of you know him for his founding and ongoing involvement in the annual course, A Comprehensive Review of Movement Disorders in Aspen, Colorado. He has mentored numerous fellows and other trainees, many of whom have become leaders in the field of neurology and movement disorders, and it's a great pleasure for me to introduce Dr. Jankovic, who will speak on shakes, twists, and jerks. Can we diagnose them and treat them? Joe.
Well, thank you, Professor Stern, and congratulations on your presidency and the leadership that you have provided to the Movement Disorder Society. When I was contacted by the Society and was told that I was selected as the 2014 Stanley Fahn Lecturer, I was obviously deeply touched and honored. Then I was asked to provide the name or topic for the lecture, and that was not easy. It was about 6 months ago. I was not really in a mindset of thinking about the lecture, so I tried to think of some generic topic that would give me the freedom to talk about anything. And this is the topic that I chose: shakes, twists, and jerks. Can we diagnose them and treat them? And what I hope to do is share with you some of the things that we are currently thinking about and doing in our center. Now, I must say that the close relationship that I share with Stan Fahn is certainly one of the highlights of my both personal and professional life. Stan was clearly my mentor. He is the one who inspired me to seek movement disorders as my future. Since my early days at the Neurological Institute at Columbia, we have shared a very close friendship. This is taken from a centennial celebration of the Neurological Institute in September 2009. Many of you have seen this picture, which is an important picture because it was taken at a time when the original founders of the Movement Disorder Society met in Hamburg in 1985. This was taken by my wife, Kathy, and it shows some of the founders, including Dr. Fahn, David Marsden, Andy Lees, and Eduardo Tolosa. And that was sort of the beginning of the society, and since that time, as you recognize, the society has grown into a major international organization with many accomplishments and lots of money in the bank, which is great. Many of you who know me know that I like to take pictures, and this is one of my favorite pictures that I took in Aspen. As Dr. Stern pointed out, one of my joys is to have conversations with Stan during the Aspen course. But in the early days, David Marsden was the co-faculty, so there were the three of us. And this is taken during one of our pleasant evenings in Aspen, Colorado. David Marsden was replaced by Mark Hallett after David's untimely passing, and this is a more recent picture where we feature our most recent edition of the book on movement disorders, which is based on some of the lectures that we give in Aspen. So let me just briefly outline what are some of the topics I thought I would want to cover. So we've been interested recently in some of the sensory aspects of movement disorders. There has been a great deal of attention paid to the non-motor aspects of movement disorders, but very little, I think, has been paid to the sensory aspects. So I will share with you some of the thoughts about sensory aspects of movement disorders. One of our other major areas of interest, especially more recently, is genetics, and I will talk a little bit about some of the genetic discoveries and how they help us diagnose unusual movement disorders. We've been also interested in autoimmune movement disorders, and I will just touch lightly on that topic, and I hope I'll have time to conclude with some remarks about some of the novel treatments of hyperkinetic movement disorders. So let me start with the sensory aspects of movement disorders. Again, this is something that I don't think has received a great deal of attention, even though non-motor aspects of movement disorders have been emphasized in many recent reviews and meetings. An example of a sensory aspect of movement disorder is alleviating maneuver. This has been traditionally referred to as just antagonist or sensory trick, but we, together with Mark Hallett and one of my fellows, Dr. Patel, felt that this is really not an appropriate term because not all of these maneuvers involve sensory input, and they are not really tricks. So we prefer to use the term alleviating maneuver. And here you see some examples touching the face. This woman, if she puts a book or some object on the vertex of her head, she can correct her enterocollis, and there are other examples of patients with blepharospasm using a variety of these alleviating maneuvers. We still don't have a clear understanding of the mechanism of these alleviating maneuvers, but functional MRI studies have provided some insight in that attenuation of the muscle activity is associated with reduced activation of the supplementary motor and the primary sensory motor cortex. This is a study that has not yet been fully published, although has been accepted by JNP, and it's based on our collaboration with the Dystonia coalition, where over 1,000 patients now have been characterized, patients with cervical dystonia. We examined the videotapes of these patients. They all underwent standardized video protocol. 154 people were studied, and 90% of them reported alleviating maneuvers. 43% had partial improvement, and about 40% had essentially complete improvement in their abnormal postures. Most of the alleviating maneuvers involve touching of the lower face and chin, and this is something quite familiar to all of you. What was surprising to us that there was really no correlation between the improvement by these alleviating maneuvers and the severity of dystonia. Now, there are many other examples of sensory aspects of movement disorders. All of you are familiar with premonitory sensation in patients with Tourette syndrome. Restless leg syndrome is probably the best example of an abnormal sensory motor integration resulting in disabling symptoms. And here we list many other movement disorders that have sensory aspects to them, including Parkinson's, dystonia, and many other, I just mentioned, restless legs, akathisia, stereotypies. But I want to draw your attention to this, what I consider sort of a new term for a movement disorder, which is very, very common. And I refer to it as a leg stereotypy disorder, or LSD. I think all of you are familiar with that, and as I look in the audience, I actually see some of you having this disorder. It was not really previously characterized, yet it's one of the most common movement disorders. Often it's observed in people who are sitting in a meeting, particularly if it's a boring meeting. These are stereotypic 1 to 2 hertz rhythmical flexion extension movements. They are often familial, so this is clearly a genetic disorder. In contrast to RLS, there's no diurnal variation, and there's really no unpleasant sensation associated with that. Let me show you a video of father and son with this condition.
Left leg, is that right?
Yes, sir. Yeah, it's just, I wouldn't say it's restless. It's just, it's almost a natural thing I don't even know I'm doing most of the time.
When you are sitting in a meeting and you are making this movement in your leg, what happens to people around?
Oh, it's very noticeable. I'm getting comments all the time. I can't sit still, and you know, it's kind of distracting for others.
Now, sir, you apparently have a similar kind of habit. Let's call it a habit for right now.
Right.
How long have you had it?
My wife would know. I think ever since I met her, I think, you know, I've been very, almost like hyper movement.
But your wife said that when you are sitting in church, you have it essentially.
She'll put her hand on my knee to stop me because she says I'm shaking the whole pew where everybody's, you know, sitting. So it must be pretty hard and pretty strong.
So again, most of you are familiar with this, and many of you know friends who have it. How many of you in the audience have it? Quite a few. Look at this. Yet this disorder has never really been characterized, so it's something that we want to spend some time on in the future, trying to characterize the genetics of this disorder and the pathophysiology of this disorder. So let me now shift to another topic, namely how genetic tests can help us diagnose the unusual movement disorders. So let me show you an example. So this is an 11-year-old boy who was able to walk and run until age 8 when he developed progressive generalized dystonia, diurnal variation, myoclonus, bradykinesia spasticity. There was marked improvement in dystonia with levodopa, but he soon developed a wearing off effect, and levodopa-induced dyskinesia. CSF studies showed low tetrahydrobiopterin and low homovanillic acid. Family history was unremarkable, except that one maternal grandmother had Parkinson's disease. So we did the usual investigation, including GTP cyclohydrolase, looking for any genetic abnormality that would help us diagnose this dopa-responsive dystonia phenotype, together with spasticity. There were obviously some atypical features, so we were not surprised that the GTP cyclohydrolase test came back negative. So here, let me just show you the video of this patient. He clearly has evidence of dystonia, dystonic tremor, and then you can see this stiff spastic gait. In an off state, 5.5 hours after last levodopa, there's a marked exacerbation of his dystonia, and in fact, at the end of the day, he's wheelchair-bound or bedridden because of the severe dystonia. He soon after he was started on levodopa, developed levodopa-induced dyskinesia, as you can see here. We obviously were puzzled by this unusual movement disorder, looked at MRI, didn't see anything specific here except for some white mattered periventricular changes. But we were struck by this thin corpus callosum, particularly in the anterior third of the corpus callosum. And in contrast to typical DRD, on that scan, he had severe deficiency, nigrostriatal dopaminergic deficiency. deficiency. So that already told us that he obviously doesn't have typical DRD. The functional MRI showed evidence of cortical basal ganglia overconnectivity, as shown here. So we performed whole exome sequencing, and to our surprise, he had heterozygous compound genotype in a gene coding for SPG11. So there were two mutations, E1630X and L23004, which we felt were pathogenic, and targeted SPG11 sequencing of both parents showed that one parent had one gene mutation, the other parent had another gene mutation. So I'm using it as an example where whole exome sequencing can be extremely helpful in diagnosing unusual movement disorders. So hereditary spastic paraplegia due to SPG11 is well recognized. It's usually characterized by spasticity, cognitive impairment, and the thin corpus callosum that I showed you. 7 other patients have been reported in the literature that also had, in addition to spasticity, dystonia and Parkinsonism, but none of the patients had the DRD type phenotype that I showed you in our patients. So we thought our patient was clearly unique, and certainly levodopa-induced dyskinesia can rarely occur in typical DRD due to GTP cyclohydrolase deficiency, but it's uncommon, whereas in this patient it occurred relatively early. So this genetic abnormality expands the characteristics of not only SPG11 but also of DRD. And here I list some of the causes of DRD. Almost everybody first thinks of GTP cyclohydrolase, which is probably the most common cause of dopa-responsive dystonia. But there are many other causes, including tyrosine hydroxylase deficiency, sepiapterin reductase, pyruvyl tetrahydropterin synthetase, ataxia telangiectasia, PARC2, SCA3, and then SPG11 can be added to the list. And all of these have different characteristics that perhaps help differentiate clinically between the different types of DRD, but certainly genetic tests are increasingly important in differentiating the different types of the DRDs. So this is taken from a recent publication from Baylor College of Medicine, our genetics group of whole exome sequencing of 250 subjects. And what was remarkable in that study that 85% of the individuals whose blood was submitted, whose DNA was submitted for analysis, had a neurological disorder. So I think of all the whole exome sequencing tests done, not just at Baylor, but worldwide, clearly neurologic syndromes represent the majority. So I want to draw attention to this paper because it highlights sort of a changing role for us as neurologists and movement disorders specialists in particular. And it says that next generation sequencing demands next generation phenotyping. And I want to draw attention to at least 2 particular points that these authors make. One is that diagnostic skills of medical specialists will shift from pre-next generation sequencing test differential diagnostic mode to a post-next generation sequencing test diagnostic assessment mode. So many of you probably already experienced that when you send a test for whole exome sequencing, it comes back with lots of data, pages and pages and pages of data. And you wonder, well, what am I going to do with this data, particularly if there's not a specific pathogenic mutation found? So I think in the future, we're going to be called upon to make some sense out of this data and rely on our clinical skills and knowledge of the phenotype to interpret this vast amount of genetic information. In that regard, I draw attention to another paper just published in Nature suggesting certain guidelines for investigating the importance and specificity of these genetic variants in order to make sure that they are truly pathogenic. I'm happy to announce that Baylor College of Medicine was just awarded a multi-million dollar award from NIH. We are one of 6 centers to pursue the undiagnosed disease program, so we'll have an opportunity to evaluate all these patients who are referred to us with undiagnosed diseases and use whole exome sequencing and whole genome sequencing to hopefully find the correct diagnosis. Okay, I'm going to shift to another topic, and I want to introduce it by showing you this patient, a 3-year-old boy with subacute onset of myalgias, frontal headache, malaise, vomiting, had obviously encephalopathic picture, dysarthria, motor aphasia, was diagnosed with viral encephalitis. He was hospitalized because of generalized seizures, dysautonomia. He had orofacial stereotypies, dystonic contractions of left side of the face, blepharospasm, dystonic flexion of the right hand, generalized chorea, opistotonic posturing. And here you can see his video. Again, you see the orofacial stereotypy and dystonia, the dystonic movement, especially in the left arm. He also had some opistotonic posturing. Clearly a severe encephalopathic disorder manifested by a variety of hyperkinetic movement disorders. We started him on tetrabenazine, and within a week or so after starting tetrabenazine, he had marked improvement of the hyperkinetic disorder. So this patient is this subject number 3 in a series that we recently reported in movement disorders. And the purpose of this report was to draw attention to anti-NMDA receptor encephalitis, particularly in children. And what we try to point out is that this disorder can present with just about any movement disorder you can imagine. This patient had predominantly dystonia and stereotypy, but there were patients who had myarrhythmia, the slow rhythmical type movement, either in the face or in the limbs. Some patients had chorea, dystonia, ataxia, and so on. So the point is that if you see an individual with subacute onset of hyperkinetic movement disorder, think of anti-NMDA receptor encephalitis. This is often initially misdiagnosed, as it was in almost all our children. And again, I just want to emphasize the variety of hyperkinetic disorders that can be seen. This is a potentially life-threatening disorder. If it's not diagnosed early, the patients can die, and there have been some legal cases already where the diagnosis was not made in time and the individual actually died. One should consider looking at evidence of underlying tumors such as teratoma. Immunotherapy is obviously very effective, including solomedrol, IVIG, plasma exchange, and rituximab. And as I showed you in this case, tetrabenazine can be a very effective symptomatic treatment. Now, I highlighted children, and most of the individuals with NMDA encephalitis are children, but here's a report of adults with this disorder. About 5% of all adults of all people with MDR encephalitis are adults, and in contrast to the children, the adults tend to have lower severity of the disorder, but worse outcome because it's often misdiagnosed, so the diagnosis is delayed. And again, movement disorders play an important role as a presenting feature of this disorder. So that introduces the topic of autoimmune movement disorders, something we've been interested in and reviewed this in this article a couple of years ago. And one of the things that we try to do is to provide some classification for these autoimmune disorders. And we divided the different antibodies into those that were directed against intracellular antigens, and these are commonly paraneoplastic. Membrane antigens that are less commonly paraneoplastic, and then other antigen antibodies that are rarely paraneoplastic. And there's a whole host of antibodies, and this list grows almost weekly. And again, it's important to recognize that some of these autoimmune disorders may also be paraneoplastic. So finally, I just wanted to say a few words about treatment of hyperkinetic disorders, and I want to specifically focus on VMAT2 inhibitors. Now, I already mentioned tetrabenazine. Tetrabenazine is a drug that I've been very interested in. In 1979, I obtained an IND from the FDA and have treated thousands of patients with tetrabenazine. As you know, the primary mechanism of action of tetrabenazine is VMAT2 inhibition, and as a result, it causes presynaptic dopamine depletion. It was approved in the United States in 2008 for the treatment of chorea associated with Huntington disease. There are some other drugs that are tetrabenazine type analogs that are currently being investigated, at least in the United States, and that's why I thought it might be important to bring it to the attention of the European audience. One is the NBI 98854, which is a prodrug of alpha dihydrotetrabenazine, for an active metabolite of tetrabenazine, and then SD809, which is a deuterated tetrabenazine. So this is the NBI 98854 VMAT2 inhibitor. It has some advantages over tetrabenazine in that it has a lower PK variability. It can be administered as a QD or BID dose. It is much more active than the parent compound, and it is currently studied in tardive dyskinesia. We've been very interested in SD809 and are participating in some clinical trials of SD809, which is a deuterated tetrabenazine. So here you can see tetrabenazine is rapidly metabolized to active metabolites alpha hydrotetrabenazine, beta hydrotetrabenazine, and then it is metabolized by CYP2D6 to O-desmethyl hydrotetrabenazine. A deuterated tetrabenazine, which provides a stronger bond between the carbon and deuterium than the carbon-hydrogen bond, and it results in increased energy that's required to break the bond, and as a result, there's an attenuated metabolism, which then results in increased active metabolites, namely the alpha and beta hydrotetrabenazine, which then results in increased area under the curve because of the attenuated CYP2D6 metabolism. So you can see here the sort of PK type data from tetrabenazine, the peaks and valleys, whereas deuterated tetrabenazine has lower frequency of these peaks, longer area, higher area under the curve, reduced Cmax, reduced dosing frequency, a lower rate rise, and probably a lower fluctuation. So it's one of the advantages of SD809 over tetrabenazine. There are currently several studies going on in the United States, mainly conducted by the Huntington study group and sponsored by Auspex. This is a randomized double-blind placebo-controlled study of SD809 in the treatment of chorea associated with Huntington disease, and there is an open-label extension where patients are then rolled over to the SD809 from the double-blind study. And there's also a switch study where we take patients who are on a stable dose of tetrabenazine and switch them to SD809, and hope that soon we'll be able to report to you the results of this particular study. So there are many new developments in the treatment of Huntington disease, particularly the chorea associated with Huntington disease, and I just gave you some examples, but there are many others, and actually the pipeline in Huntington disease, in my opinion, is actually much healthier than what we see in Parkinson's disease. As you heard yesterday, there was some pessimism expressed about the pipeline in Parkinson's disease, but in Huntington disease, there are a number number of potential compounds and molecules that are currently being studied, and I just listed some of them, including the deutetrabenazine. You heard about predopidine during Professor Carlson's lecture, as the first lecture of this Congress, but there are many other developments, and I think that the field of Huntington disease therapeutics is really quite exciting. Just a few words about medical treatment of dystonia. I'm not going to belabor that. Professor Berardelli already alluded to this review, which was an evidence-based review, where we looked at botulinum toxin in different indications, such as cervical dystonia, blepharospasm, and so on, and assigned levels of recommendation on the 4 types of botulinum toxin: ABO, ONA, INCO, RIMA, botulinum toxin, and you have to remember all these proprietary generic names in order to understand which type of botulinum toxin actually you are talking about. As you know, botulinum toxins, they all work through the Snare proteins. They cleave SNAP25 or synaptobrevin or syntaxin. And this topic of Snare was the topic that was discussed at a time when Nobel Prizes were awarded just last year in 2013. It's timely to actually draw attention to those 3 individuals, Rockmond, Sheckman, and Sudov, who received Nobel Prize in 2013 for their work on the Snare proteins. And in one of the reviews, it says snares are key elements in the function of botulinum toxin, and dysfunction of snares plays a key role in Parkinson's disease and other neurologic and psychiatric disorders. So James Rothman also was a speaker at our Toxins 2012 meeting in Miami, and I guess I had a vision at the time that he will eventually get a Nobel Prize, so I want to take the opportunity to take a picture with him. This is probably as close as I will ever get to a Nobel Prize, but I thought it was a golden opportunity. So that reminds me to remind you about Toxins 2015, which is going to be our next major meeting on botulinum toxins. What is the answer to the question, can we diagnose them and treat them? Shakes, twists, and jerks. Well, I'd say yes, most of the time, but there's still so much to learn and so much to discover. This is the world's largest medical center, the Texas Medical Center. This is our new facility where we're going to be moving to in December. So I hope some of you will come and visit us. And I want to thank the President and the President-elect for introducing me and for giving me the honor to give this Stanley Fahn lecture. So thank you very much.
One of the great pleasures of being in this position is to be able to award young scientists coming up in the field, and the junior awards have been selected based on their significant contribution to research in the field of movement disorders. And it is my pleasure to introduce Dr. Julia Müllner, who trained at the University of Cologne Medical School, and she's now a fellow in the Department of Movement Disorders, University Hospital in Bern, Switzerland. Dr. Müllner will talk about dopaminergic denervation severity depends on COMT Val158 MET polymorphism in Parkinson's disease.
Good morning, ladies and gentlemen. Thank you for the kind introduction. I would very much like to thank the board for giving me the opportunity to speak today and to having chosen my project for the Junior Award. So my name is Julia Müllner. I'm presently working as a fellow in the movement disorder outpatient clinic at the University Hospital in Bern. And I would like to present a project I did when I was working as a research fellow at the Hôpital de la Salpêtrière in Paris, which was investigating the impact of COMT Val158 158 MAD polymorphism on dopaminergic denervation in Parkinson's disease. As you all know, the neuropathological correlate of motor symptoms in Parkinson's disease is a progressive degeneration of dopaminergic neurons in the substantia nigra. At motor symptom onset, however, there's already a loss of 40 to 60% of dopaminergic neurons, and there is a striatal denervation of about 80%. Looking at disease progression, we therefore have a premotor and a motor phase. Within the premotor phase, we already have non-motor symptoms such as hyposmia, constipation, or REM sleep behavior disorders. However, motor symptoms are counterbalanced by compensatory mechanisms, and it's only when these compensatory mechanisms are insufficient that motor symptoms become clinically relevant, even though the dopaminergic denervation might have been going on for years. Looking at dopamine metabolism, dopamine is synthesized from tyrosine to L-dopa and then to dopamine, released into the synaptic cleft where it reacts on dopamine 1 and 2 receptors. It is then cleared from the synaptic cleft by the DUT and two enzymes, the MAO and the COMT enzyme. In striatal denervation, the dopaminergic turnover is enhanced, showing a higher activity of the enzymes involved in dopamine metabolism. And this has been shown in mouse, monkey, and in vivo PET studies that also show that the DUT expression is diminished in dopaminergic denervation. However, the role of the COMT enzyme in counterbalancing dopaminergic denervation has not been clear so far. To investigate this, we took advantage of the COMT enzyme genotype. Indeed, the COMT enzyme has a functional polymorphism at codon 158, showing two codominant alleles which act on enzyme activity. This results in a trimodal distribution of enzyme activity, dividing it into, oops, I have to go back. Okay, thank you. Dividing it into high, intermediate, and low metabolizers. High metabolizers have a 2 to 4 times higher enzyme activity than low metabolizers. The COMT enzyme genotype has already shown to play an important role as a modifier in the age of onset of motor symptoms in Parkinson's disease. This has been shown in a large genetic study involving almost 6,000 Parkinson patients and almost 10,000 healthy controls. Two important results were shown in this study. First, the COMT enzyme genotype was not associated with Parkinson's disease and is therefore not a susceptibility factor for Parkinson's disease. But second, the COMT enzyme genotype was associated with the age of onset of motor symptoms, showing that in high metabolizers, motor symptoms were present almost 2 years prior to motor symptoms in low metabolizers. From these findings, we formulated our hypothesis that COMT activity may interact with compensatory mechanisms in the delay of motor symptom onset in Parkinson's disease, and the COMT BAL158 polymorphism may play a modifying role in motor symptom severity. Our objective was to show that dopaminergic denervation is different according to COMT polymorphism when adjusted to motor severity in Parkinson patients. The data we used were obtained from a clinical trial at the time ongoing at the clinical investigating center in Paris, which looked for the effect of apamine subcutaneous injection in Parkinson's disease. Inclusion criteria were idiopathic Parkinson's syndrome according to United Kingdom Parkinson's disease brain bank criteria, Hoehn and Yahr stage of 2 to 3, and age of higher than 40 years. 44 patients were screened, and they had to have a pathologic SPECT and a normal brain MRI. UPDRS3 was assessed in off state after a washout period for dopamine agonists of 72 hours and L-DOPA agents for 12 hours. The examiner and the patient were blinded for genotype status, and clinical data was obtained before any application of apamine treatment was done. So this was only baseline data that we used. Genotyping was performed using the Tachman method, and the dopaminergic denervation was assessed with the SPECT imaging. In the SPECT images of all the patients, we defined a region of interest and a region of non-specific activity. Images were normalized to intensity and space, and these normalized images were then compared voxel by voxel to healthy controls, and thus dopaminergic denervation was defined for each patient. This was done not only for the striatum in total, but also for striatal subregions. 44 patients screened, 2 patients had vascular abnormalities on brain MRI, and therefore couldn't participate in the genetic study. 1 had a normal SPECT scan, and 1 patient refused to participate in the genetic study. As you see in this table, we had 11 high metabolizers, 26 intermediate metabolizers, and 3 low metabolizers. Patients' characteristica for age of onset, sex, and UPDRS3 were equally distributed over groups, so there were no significant differences between groups. As an internal control, we checked for the correlation between dopaminergic denervation and UPDRS3 score, which showed a significant negative correlation. In a multivariate analysis, including age, sex, and UPDRS3 score, we found that genotype had a significant effect on binding potential in the striatum. High metabolizers, as you can see in this graph, showed a higher binding potential than low and intermediate metabolizers. This was true not only for the striatum in total, but also for striatal subregions. We found the same genetic effect in men and women. There was an independent effect of gender, showing that women have a higher binding potential in the striatum than men, and this was consistent in all genotypes. However, we didn't find a gender-genotype interaction. This led us to the conclusion that in Parkinson patients, a lower COMT activity is associated with a higher dopaminergic denervation at the same level of clinical severity. Or turned around, clinical severity is higher in high COMT metabolizers at the same level of dopaminergic denervation. An increase in dopamine bioavailability has been shown before in the prefrontal cortex, and this was shown once in a postmortem study in mice and in a in vivo study with stereotactic stimulation in the median forebrain bundle. They showed a sex dimorphism for dopamine bioavailability in knockout mice in the prefrontal cortex, which was not shown in the striatum. Therefore, the authors of this study followed that the importance of the COMT enzyme is much higher in the prefrontal cortex than it is in the striatum, where dopamine clearance is mostly defined by the dopamine transporter. But as we learned before, in striatal denervation, the expression of the DAT is diminished, and therefore we think that the role of the COMT enzyme changes in striatal denervation. This is why we interpreted our results as follows. In PD patients, lower COMT activity may increase bioavailability in the striatum and thus interact with compensatory mechanisms counterbalancing the clinical effect of dopaminergic denervation. Of course, there were some limitations to our study. Our patients were quite advanced in their disease. Even though we followed a strict washout period scheme, we cannot rule out any long-term effect of treatment, and we had a rather small sample size. Therefore, an ideal setting would be de novo patients who are drug naive, and of course, a much larger patient population. This was my presentation. I would very much thank you all for your attention. And my special thanks go to Andreas Hartmann, who let us share the data of the Apamine trial, and of course, Jean-Christophe Corvol, who has been a great teacher and supporter in my time at the Salpêtrière Hospital. Thank you very much.
Ladies and gentlemen, it's my pleasure now to announce the second Junior Award, which will be given to Anhar Hassan. She has a remarkable career. She did her medical school in Dublin at the Trinity College. She did her residency in Brisbane and Sydney, Australia, and now she has a fellowship training. She had a fellowship training at the Mayo Clinic and at the University of Florida, and is currently an assistant professor at the Department of Neurology at the Mayo Clinic in Rochester. We are looking forward to your presentation.
Thank you very much for the introduction. This is research that I undertook during my fellowship at the University of Florida. So it's titled The Profile of Long-Term Parkinson's Disease Survivors with 20 years disease duration and beyond. I have no disclosures particularly relevant to this study. So Parkinson's patients have reduced survival compared to age-matched peers, and factors identified are those of older age at onset of Parkinson's disease, male gender, a lack of tremor-predominant Parkinson's, as well as higher mortality attributed to pneumonia, psychosis, and dementia. There are very few natural history studies that look at the long-term survival of Parkinson's patients. The hallmark study by Healy et al. Is from the Sydney multi-center study, and this looked at 20-year follow-up of community-dwelling Parkinson's patients. Very few of those patients survived 20 years. 136 patients were followed at baseline, and at 20 years survival, only 30 were still alive. Of those patients still alive, the majority were demented, 83%, and half of them were nursing home residents, which paints a rather dismal picture of long-term survival in Parkinson's disease. Other natural history studies vary from about 10 to 15 years follow-up and are similar in terms of reporting of mortality and high morbidity in survivors. Overall, though, Parkinson's patients with 20 years survival and beyond are not well characterized, so there's very few numbers of these patients described. Studying long-term Parkinson's survivors is important for two reasons. Firstly, to identify favorable Parkinson's disease characteristics that might translate into longer survival. And secondly, improving healthcare delivery specifically targeted at that population of patients. And it's important because there is an exponential increase in the number of Parkinson's disease survivors predicted in coming years, and with that will be an increased number of long surviving patients. So the objective of the study was to describe the characteristics of patients with at least 20 years or longer Parkinson's disease survival, designated as PD20+, in the remainder of the talk. We utilized data from the National Parkinson's Foundation Quality Improvement Initiative study. This study was started in 2009 and enrolls PD subjects that are attending National Parkinson's Foundation Centers of Excellence at 20 international sites. The majority of the sites are in the United States and a couple of sites in Canada, one in Israel, one in the Netherlands. There's a uniform data set that is collected annually on these patients, and this comprises demographic information, clinical data, and instrumental data. And the instruments used are the timed up and go, a MoCA estimate, which is derived from delayed verbal recall and verbal fluency, PDQ-39, and the multidimensional caregiver strain index. So we performed a cross-sectional study, and we identified all patients with at least 20 years of Parkinson's disease duration, comprising 187 in total, within the MPF-QII database. And at the time of the study, 4,619 patients were enrolled. We extracted demographic and clinical data. We also performed a subgroup analysis. So we compared patients who were younger than age 70 compared to those age 70 or older, both with 20 years disease duration or more, to see whether age played into the outcomes. So these are our results. We found 187 PD20+ patients. These comprised 4% of all patients within the database. On average, they were currently age 69, and they had Parkinson's disease onset at age 44. 55% of these were male. Their disease duration is graphically depicted. The range of disease duration varied from 20 years up to 49 years. 75% of patients had disease duration up to 25 years. The age of onset is shown here on the same graph as their current age. You can see that there's a cluster of age of onset between age 36 and age 50, or actually age 36 up to age 55, and all of the PD20 patients had age onset at 65 or below. Their current ages are clustered between ages 61 and 75. Interestingly, 55% of patients had rest tremor documented. 3/4 of them had motor fluctuations. The median Hoehn-Yahr score was 3. There was a very low number of comorbidities, given 20 years of Parkinson's disease, at 1.9 on average. And 41% had at least one hospital contact visit in the last year, hospitalization, an ER visit, or both. Looking at their social outcomes, the majority of patients, surprisingly, were still living at home. So 89% of these patients with 20 years disease or longer were still living at home. 10% were in a skilled facility and 1% in some other type of facility. And most of them required a caregiver. The burden mainly fell on the spouse or partner in 68%, followed by another relative, and then a paid caregiver. Only 12% of patients did not require any caregiver at 20 years disease or longer. Looking at medications, almost all patients were on levodopa. The second most commonly used medication was dopamine agonists, and then amantadine. Looking at other medication use, about 40% of patients were using an antidepressant. Surprisingly, for 20 years of disease duration and beyond, there were a small number of patients on cognitive enhancers or antipsychotics, at less than 20%. Looking at other therapies, about 50% of patients reported some form of exercise. However, the type of exercise, the intensity, and the frequency is not known. Physical therapy was one of the most commonly used therapies, and then the other ones listed there were less frequently used. There was a low rate of referral for social work or mental health input. Looking at the instrumental measures of cognition, overall, there was mild cognitive impairment in these patients with 20 years survival or longer. The MoCA estimate was 22.6, and recall this is derived from the delayed word recall of 5 words and verbal fluency. And the MoCA estimate is believed to be reflective of MoCA. Regarding quality of life outcomes, most patients reported mild to moderate disability, and they perceive their disability to be relating to their impaired mobility and ADL subscores, where they scored highest. Regarding caregiver burden, this was approximately mild to moderate severity at 26.5%, and caregivers rated social constraints as being the highest source of burden. Looking to the subgroup analysis of Parkinson's patients aged below age 70 with 20 years disease duration, there were 90 in this group. Compared to those aged 70 or older, there were 97 patients. And they surprisingly only differed significantly relating to cognition. There was worse cognition in the older patients, but they did not differ significantly by any of the other factors that I've gone through in the results. So, PD20 subjects enrolled in the NPF-QII study reflect an elite group or elite subgroup of long-term survivors. Overall, they have mild cognitive disability and moderate motor disability. Most had younger onset Parkinson's disease, and all had onset below age 65. It's known that younger onset Parkinson's disease allows a more benign course, permits longer survival, and there's less dementia associated. Interestingly, dementia was not as frequently documented as one would have anticipated, because tremor-predominant Parkinson's disease is thought to be related to a more benign course. So one would have anticipated a higher frequency there of tremor-predominant disease. Most were living at home, and this is likely reflective of the fact there is a mild cognitive burden that allowed them to remain in their home environment. However, most required a caregiver. There was mild to moderate reduction in quality of life at 20 years of disease duration and out, and again, this mainly relates to motor disability. Interestingly, half of these patients were still exercising at 20 years duration and beyond, and this is of interest given the putative role of neuroprotection of exercise relating to Parkinson's outcomes. There were a low number of comorbidities at 1.9 on average at 20 years disease duration, and this may also have played in to their survival outcomes. So 4% of patients captured in this study had at least 20 years disease duration, and this study was derived again from the MPF Center's patients. This may actually reflect the frequency in other specialist clinics of the number of long-term survivors that are seen, and raises the role of Parkinson's disease specialist clinic input into contributing towards the good outcomes in these patients. So that the extent of that role is unknown. Coming back to our subgroup analysis, again, it was surprising there was no cognitive decline. It was surprising that cognitive decline was the only difference between the two subgroups separated by age. One would have anticipated worse age-related mobility, higher number of comorbidities, higher caregiver burden relating to an older spouse, or a different pattern of medication use in those patients below age 70 with 20 years disease duration or more compared to those 70 or above. The limitations of this study is that it's a cross-sectional study. So this is not applicable, this is not going to be the outcome for all patients with Parkinson's disease. There's survival bias. We don't know the denominator which these 187 Parkinson's patients were derived from. There's sampling bias. These patients happen to be attending MPF Centers of Excellence and then were enrolled in the study. There may also be recall bias for patients that enter the study at a later age and incorrectly reported their age of disease onset, for example. There were some data set limitations. We didn't capture genetic data, and a larger portion potentially of these younger onset patients may have had genetic Parkinson's disease, which does better in the long term. Regarding the study's strengths as a uniform data set, there were a large number of PD20 patients characterized, and there are multiple geographic sites, and these patients are community-based subjects. Potentials for improving healthcare delivery in these long-term survivors should focus on emphasizing their motor disability and improving their ADLs, because they self-report this is where their largest proportion of impaired quality of life comes from. Support should be given to offset caregiver burden, and there should be anticipation for hospitalization, as 41% of patients had a recent hospital contact within the last year. Regarding future research, the MPF QII study data will be most interesting to follow patients prospectively over the next 20 years to see what the outcomes are as a natural history arm of this as a comparison. And then it would also be of interest to compare PD20 outcomes in other PD specialist clinics to see if these findings can be replicated. So in conclusion, PD20 subjects reflect an elite group of Parkinson's disease survivors. They have better than anticipated cognitive and functional outcomes despite advanced Parkinson's disease. And this is in contrast to the supposed inevitability of dementia at 20 years disease duration and beyond. And focusing on mobility and ADLs and caregiver support may translate into better care of these patients. Thank you. So I'd like to acknowledge the National Parkinson's Foundation, the Parkinson's disease subjects and their families, and my co-authors. I'd like to thank in particular Michael Oken, who was my mentor for this study, Samuel Wu, our statistician, and Peter Schmidt from the National Parkinson's Foundation, and the MPF centers who took part in the study are listed on the right. Thank you.
So the next awardee is Samuel Shribman from London, United Kingdom. He had his preclinical medicine training at Cambridge University, then changed to the University College in London, where he also graduated in medicine. Before he had a master's in pharmacology. And he's now working at the Hammersmith Hospital in London. Thank you very much for your presentation.
Good morning. Thank you very much for the kind introduction, and thank you for the opportunity to speak today. I'm going to present you a piece of work that was investigating the enteric nervous system that was started in late 2012 at the National Centre for Bowel Research in the UK. And I think that the study of the enteric nervous system in neurology is both incredibly exciting and important at the moment, not only as a means to understanding important gastrointestinal symptoms associated with neurological diseases, but also and perhaps more so because the enteric nervous system can act as a more easily accessible surrogate for the central nervous system. And as I'll discuss, this means the potential to make tissue diagnoses of neurodegenerative diseases like Parkinson's disease during life. So, to explain the background to this study, several immunohistochemical studies on the GI tract have demonstrated that alpha-synuclein and phosphorylated alpha-synuclein in abnormal linear or globular aggregates that resemble Lewy pathology in the brain can be detected at multiple sites in the gastrointestinal tract, in Parkinson's disease patients, but not in controls. And in an exciting study by the INSERM consortium, this concept was extended to biopsies of the colon taken during a routine colonoscopy. These were biopsies that were stained using a novel whole mount staining mechanism method, and they were dissected down, containing thick sections of tissue to reveal the submucosal plexus. And this concept was further extended in subsequent studies that have demonstrated that these biopsies of the colon that are taken prior to the onset of motor symptoms can also demonstrate these aggregates. And in one case, this was 8 years before the onset of motor symptoms. So this was of particular interest to our group, who have been developing a means with which to try and determine which members of the general population are going to develop Parkinson's disease. In the PREDICT-PD study, colleagues have been assessing for early non-motor features of Parkinson's disease in members of the general population to try and risk stratify members of the general population into risk for developing Parkinson's disease later in life. And what's clear is that the ability to determine which of our high-risk cohort are going to develop Parkinson's disease would be greatly improved by the ability to have a tissue diagnosis of pre-diagnostic Parkinson's disease. However, between the previous studies, there was variable reporting of the staining for alpha-synuclein, phosphorylated alpha-synuclein that's seen in controls. And some studies have said there's no background staining at all. Others have said there is some background staining, but it's not considered to be significant because it doesn't look like a linear or globular aggregate. However, we felt that if we're potentially going to use enteric tissue to make a distinction between our high-risk members of the general population who are going to develop Parkinson's disease and those who won't, it's really crucial to understand all of the different staining patterns for alpha-synuclein and phosphorylated alpha-synuclein in our controls. So we set out first to optimize antibodies to alpha-synuclein and phosphorylated alpha-synuclein using brain tissue. And then we hope to characterize the distribution of alpha-synuclein and phosphorylated alpha-synuclein in the enteric nervous system of controls. Finally, in a smaller number of Parkinson's disease cases, we hope to explore some of these characteristics in the enteric nervous system as well. So, using the LB509 antibody to detect alpha-synuclein and the phosphorylated alpha-synuclein antibody, the 11A5 antibody to detect phosphorylated alpha-synuclein, we first optimized our staining methods for each antibody using Parkinson's disease and control brain that was kindly donated by the Queen Square Brain Bank. These were tissues that were fixed in formalin so as to preserve the tissue morphology through protein-protein cross-linking, as you can see in this diagram. And for those of you unfamiliar with immunohistochemical methods, this routine process of fixation for these tissues, whilst preserving tissue morphology, has the side effect that it actually masks the antigens in your tissue from detection with a primary antibody. And so what's usually required in an immunohistochemical study of this type is to include an antigen retrieval step to unmask these antigens by breaking down these protein-protein crosslinks. So we wanted to optimize our antibody staining using a range of different antigen retrieval methods, because there are in fact a wide range of different antigen retrieval methods, and in the enteric PD literature, a range of different methods have been used. And to complicate matters, each individual antigen-antibody interaction responds differently to different antigen retrieval methods. So we wanted to use a wide range, and we wanted to use a range of different antibody dilutions as well to optimize our staining for detection of Lewy neurites in brain tissue. And you can see in this table the range of different antigen retrieval we use. So we use tris-EDTA buffer, citrate buffer for a heat-induced antigen retrieval at a range of pHs. We heated to temperature in water bath and microwave. We tried various different durations for heating as well. We also included an enzyme-based method for antigen retrieval with proteinase K that's previously been described in the literature. And we use that at varying dilutions and varying durations as well. And what we found was that very subtle changes in antigen retrieval methods can lead to very significant changes in our ability to detect Lewy neurites. So what I'm showing you in this slide is two images. These are both taken from adjacent slides, adjacent sections from the same patient with Parkinson's disease. They're both stained with the same antibody to phosphorylated alpha-synuclein. They use the same tris-EDTA buffer, the same pH, the same duration, the same antibody dilution. But in one, we heated to temperature in a water bath, and the other we heated to temperature in a microwave. And you can see with the positive staining in red that in the top image, we can just make out globular Lewy bodies, but in the bottom image, we can make out globular Lewy bodies and Lewy neurites. So this clearly has implications for our ability to detect Lewy neurites in the enteric nervous system as well. And then, given that previous studies had used a range of different antigen retrieval methods, this could go some way to explaining why different groups have seen different background staining patterns. Taking this further, we went on and found that the most optimized, the ideal method for staining with each of our antibodies, and you can see in the left-hand images in Parkinson's disease brain that we can see clearly Lewy bodies and Lewy neurites, and in the control brain slides on the right, we don't see any positive staining. For our LB509 antibody, that was a proteinase K-based method, and for our 11A5 antibody, that was a heat-induced method with tris-EDTA buffer. So having optimized our staining methods, we could then apply these to similar tissue sections taken from the colon in the confidence that we know that the staining pattern that we're going to see in the enteric nervous system is representative of the distribution of alpha-synuclein and phosphorylated alpha-synuclein. So we used single 6-micron sections, thin sections from resection specimens from the Institute of Pathology archives, and we had 24 controls, all sigmoid colon across a range of ages from 26 up to 88 years. We had 3 sigmoid colon and 1 ascending colon from Parkinson's disease patients, all diagnosed by Queen Square Brain Bank criteria. We stained 1 slide from each patient with alpha-synuclein using our optimized methods, and the other slide for phosphorylated alpha-synuclein, again with optimized methods. And in every experimental run, we included some Parkinson's disease brain, and we included controls that didn't have any primary antibody from each of our colon slides to ensure that there was no change in the reliability, the validity of our staining. And to analyze the slides, we went through each of the different tissue layers of the enteric nervous system and described the pattern that was seen using blinded observer reporting. You can see from this diagram, it's taken from a recent and excellent review on enteric biomarkers in Parkinson's disease by Naomi Vazanji, recently published in Movement Disorders, that the enteric nervous system can be subdivided into different sections, and you can see more luminally there's the intramucosal nerve fibers, beneath that within the submucosa, the submucosal plexus, and deeper to that still, the myenteric plexus sitting between circular and longitudinal layers of the muscularis propria. So we went through each of the different tissue layers in each of our controls and PD patients, and we characterized the staining pattern that we saw in each place. And we also recorded if we saw any of these abnormal linear or globular aggregates that might represent potential Lewy pathology. So to show you a few examples of some of the staining, and these are just examples from our control colons, again, all the positive staining for alpha-synuclein, phosphorylated alpha-synuclein seen in red. We've got a selection of images here. So for those of you who haven't looked at histopathology of the colon in a while, in the left-hand images we've got some pictures of mucosa. In the middle we've got submucosal layer that's containing, and you can see in the top image, the 2 ganglia of the submucosal plexus. And you can also see down here some vascular structures. And then in the right-hand image, you can make out ganglia of the myenteric plexus seen here, sitting between the circular and longitudinal muscle layers. And in the top row, we've got some examples of phosphorylated alpha-synuclein staining in controls, and in the bottom row, we've got some examples of alpha-synuclein staining in controls. And you can see there's a wide range of different staining patterns. So in this sample of mucosa, there's some punctate staining seen here around epithelial cells. Within the submucosa here, we've got some fine granular staining that you can make out in this inset image of this ganglia of the submucosal plexus. Similarly, there's some fine granular staining seen in this muscle layer. And then in this image of the submucosal plexus here, there's some more dense granular staining. Similarly, some dense granular staining seen in this myenteric plexus of a control colon. What these images can't really show you is the heterogeneity in staining within an individual slide. For example, some control patients had staining in the myenteric plexus but not in the submucosal plexus, and others vice versa. There's also heterogeneity of the staining within a single ganglion. You can perhaps make out in this image that certain cell bodies are more positively stained than others. But looking at the staining patterns overall, again, just in our control colons, you can see that the majority of our controls have positive staining. For alpha-synuclein, a significant proportion, in fact a majority in most of the tissue layers, have this dense granular staining that you can see in this graph in deep red here. And you can make out more fine granular staining in pink and punctate staining in a more paler shade there. Contrast that with our phosphorylated alpha-synuclein staining, and that seems to be slightly more localized with its dense granular staining to the submucosal plexus and the myenteric plexus. But overall, in our controls, 75% of our controls had staining for alpha-synuclein within the plexus, and 79% of our controls had staining for phosphorylated alpha-synuclein in the plexus. So these proteins are clearly widely abundant in our controls. And we wanted to next consider, was there any particular distribution? Could we find out which of these patients were staining and not? So we broke them down according to age. Those under 60, over 60, there's no significant difference. We looked at the distribution with sex as well. Again, no significant difference. So what about our Parkinson's disease colon? So for alpha-synuclein staining, we see a similar pattern. The majority of patients have dense granular staining in in the majority of the different tissue layers. In contrast, for phosphorylated alpha-synuclein, there's no dense granular staining seen, and there's slightly less staining seen. And it's very difficult to make any firm conclusions from this, because this is a small number of patients. But when you take this in the context of the following image, it's perhaps a little bit more intriguing. So this is an image of Parkinson's disease colon, sigmoid colon. It's been stained for phosphorylated alpha-synuclein, and you're looking at the muscle layer here. And within the muscle layer, you can make out this linear filamentous structure here that's seen in the inset. It's about 140 microns in length, and it's the same size and appearance of the Lewy neurites that we see in the brain, and it could well represent Lewy pathology in the enteric nervous system of this PD patient. But that's not the interesting thing about this slide. The interesting thing about this slide is when you look at the top here, you can make out myenteric plexus, and there's no staining seen at all. And I think of all of the patients in our cohort, the ones that you'd expect to see some phosphorylated alpha-synuclein staining in their myenteric plexus is probably the patient that's got Parkinson's disease and got evidence of enteric Lewy pathology. So this is an interesting observation. Putting our findings in the context of other concurrent studies that have recently been reported, Botner and colleagues looked in 13 patients for alpha-synuclein and phosphorylated alpha-synuclein staining, found that all of the patients, controls, had alpha-synuclein staining, a significant proportion had phosphorylated alpha-synuclein staining. Gold and colleagues focused just on alpha-synuclein staining, but they looked in much larger numbers. 52% of the general autopsy population had alpha-synuclein staining in the bowel, and 100% of their PD patients had alpha-synuclein staining. So from our findings, we can make several conclusions. I think firstly, given the wide abundance of these proteins in the enteric nervous system of controls, it's likely that it's probably the presence of linear and globular aggregates of phosphorylated alpha-synuclein or alpha-synuclein, that really the pattern of staining that's going to define what enteric Lewy pathology means, because we can't just rely on the presence of these proteins to say that this is pathological or not. I think these findings also raise interesting questions about the physiological role of alpha-synuclein and phosphorylated alpha-synuclein, given they're so widely abundant in controls. And finally, our findings in an admittedly small number of Parkinson's disease patients that there wasn't dense granular staining seen in a patient that did exhibit Lewy pathology is an interesting observation that may need to be looked at in a larger number of patients. So there are clearly limitations to this study, and in our controls, one of the most important limitations is the fact that we weren't able to follow these patients up who had colon resections many years ago and were provided through tissue archives. We weren't able to follow them up to see whether they went on to develop Parkinson's disease, because it's very possible that some of these patients actually had pre-diagnostic Parkinson's disease, and we wouldn't have known this unless we followed them up for 5 or 10 years or so. I think in our PD patients, a clear limitation is the small numbers of patients. But as well as that, I think that the use of single sections has probably introduced a sampling error for our ability to detect Lewy pathology, given that previous studies have suggested that multiple sections or thick sections or even whole mount sections of tissue are required to sensitively detect Lewy pathology in the bowel. But I think taking the conclusions and the limitations together, what this points to is the need to carry out a larger study, a study that looks not only at controls, but also in Parkinson's disease patients in larger numbers, and perhaps even in some of our high-risk members of the general population who may go on to develop Parkinson's disease, and consider not only the abnormal linear and globular aggregates, but also this background staining, which may have some relevance to defining what we understand by enteric Lewy pathology. So to summarize the findings once again for you, we found subtle variation in antigen retrievals affected our sensitivity to detect Lewy neurites. We found phosphorylated alpha-synuclein and alpha-synuclein staining was seen in the majority of our controls in a variety of different staining patterns, but there wasn't any particular pattern with age or sex. And finally, we found that granular staining for phosphorylated alpha-synuclein wasn't seen in the myenteric plexus of a patient who who potentially demonstrated Lewy neurotic pathology. I'd like to acknowledge a few people who contributed and supported to this work. Firstly, Professor Charlie Knowles for his support in the lab, in addition to his expertise in enteric neuropathy, Dr. Alison Noyes for his expertise in Parkinson's disease and the founder of Predict PD, Professor Gavin Giovannoni for his clinical support, and Professor Joe Marsden for her expertise in histopathology of the bowel, Professor Richard Paulson for his expertise in immunohistochemical methods, and Dr. Julian Fernley for supplying the PD patients, Rosemary, Debbie, and Chris, without whom the daily running of the experiments wouldn't have been possible at all, and Shira, Susan, and Wagner for their continued advice and support across the Atlantic. Thank you very much.
The David Marsden Lecture was created to recognize an outstanding scholar and inspiring neuroscientist in the field of movement disorders. This year's awardee is Professor Olle Lindvall from the University of Lund, who perfectly fits this profile. Professor Lindvall received his PhD in 1974 and MD in 1978 from the University of Lund in Sweden and has been affiliated with the school for more than 45 years. He served as chairman of the Division of Neurology until 2012, the Department of Clinical Neuroscience from 2001 to 2003, and was Vice Dean of the Medical Faculty, University of Lund, 1997 to 99. And in 2014, he was appointed Senior Professor of Neurology at the University of Lund. It would be impossible because of the innumerable achievements and contributions that Professor Lindvall has generated to enumerate all of them, but I would like to mention that he has led the clinical cell transplantation program for Parkinson's patients at Lund University Hospital between 1983 and 2012. And this program pioneered the use of neuronal replacement as a possible novel therapeutic strategy to restore function in the diseased human brain. And in that regard, Professor Lindvall will be talking about developing cell therapy for neurodegenerative disease, a lifelong journey. Professor Lindvall.
First, I would like to thank the Movement Disorder Society for selecting me to give this lecture. David Marsden was a great inspiration to me during an important part of my career. And every time I met him, as on this photograph from 1987, I felt that I got new energy in my work. David was definitely the most brilliant scientist clinician I have ever met. Trying to repair the brain and restore function in Parkinson's disease and other diseases by replacing dead cells with new healthy cells has really been a lifelong journey for me. And since you heard already yesterday about the current status of cell transplantation in Parkinson's disease, I thought that I would instead give you some personal recollections from this scientific journey, and end up by describing to you why I think we are in an extremely exciting time when it comes to cell therapy for brain diseases. When I started as a young physician in clinical neurology in 1976, after having finished my PhD thesis in 1974, the situation was very different. And the dogma of brain repair and plasticity is very well illustrated by Cajal's words. In the adult brain, the nerve paths are fixed and immutable. Everything can die, nothing can be regenerated. And when I was talking about some very exciting data that has come out from basic science in the mid or late 70s with my first boss, Ragnar Müller, who was an excellent clinician and lecturer, he just met me with strong disbelief. he said to me that the clinical application of brain repair has never been possible in the past and will never be possible in the future. But in 1979, there were two articles published which actually had clear clinical implications. And those two were published independently by the Stockholm group, together with people in the collaborators in the United States, and by the Lund group with Anders Björklund and Uns Steneve, showing that you could transplant fetal mesencephalic dopamine-rich tissue to the brain of rodents and ameliorate the symptoms of Parkinsonism in an animal model. And this, of course, triggered directly the possibility, or raised the possibility, that it would be possible to develop a transplantation therapy for patients with Parkinson's disease. I was very excited about these data, about the preclinical data, but I was very hesitant about the clinical translation for two main reasons. First, the first reason was the practical one. Would it be possible to collect human fetal mesencephalic dopamine-rich tissue from routine abortions? Would it be possible to identify the ventral mesencephalon containing the dopaminergic neurons? And finally, would it be possible to put cells into the human brain without any adverse effects? The second hesitation, the second concern was, of course, and most important, was the ethical one. Would it be morally and ethically justified to use tissue from aborted human fetuses, collect, and then transplant them to patients with severe motor problems, to Parkinson patients with severe motor problems? And this was not easy. I had, after a long, and took time, and after a long consideration, I came to the conclusion that it is, in my view, justified ethically and morally to use human fetal tissue as well as human embryonic stem cells for this purpose. But the first transplantation in the clinic were not performed with human fetal mesencephalic tissue, but with adrenal medulla tissue. And those studies were based on an article in Nature providing some evidence that grafts of adrenal medulla tissue containing, of course, catecholamines, that they could ameliorate a rotational asymmetry in a model of Parkinson's disease. And this led Erik Olof Backlund, Åke Seger, and Lars Olsson to perform two implantations, or implantation in two patients in 1982 and 83 with implants in the caudate nucleus. And when I met with Lars Olsson at the meeting, we decided that we should start a collaboration and introduce two major improvements. The first one was to implant in the putamen instead of the caudate nucleus in order to have a better chance of improving motor function. And the other was to actually improve the neurological assessment of motor function, to be able to detect also changes in parts of the body. And so actually the data from the first patients were inconclusive. So we developed a test battery to detect changes therapeutically valuable or not in motor function in patients. And patients were, then two patients were operated on 19 and 20 of April 1985. And I remember this very, very well, because in the surgery room was crowded. There were more than 20 people who wanted to be present at this unique occasion. It was the third brain transplant in the world. And I remember we also had a syringe of haloperidol available in the surgery room in case the patient would react with an acute psychosis due to catecholamine release. But nothing happened, however. And the patients were followed very closely, and we made also over the first 6 months. And I was going to report about these data at a meeting at the New York Academy of Sciences. The data showed that there was a very slight transient improvement in motor function, primarily on the side contralateral to the growth. And I remember when I was describing the data, I gave a talk at this day, April 4th, 1986, at the New York Academy of Sciences. And I was met with, the audience was overtly negative to my talk. And people literally threw rotten tomatoes at me. And interestingly, the discussion was published. So even if the text is slightly polished, we can read a statement like this by an excellent neuroanatomist, Konstantinos Sotello. Having been a neurobiologist for 25 years, I would rather do experiments in animals than in humans. By a colleague, Mark Perlow, you describe the beneficial result to catecholamine release. I don't find any evidence in your paper that there was any catecholamine release, and I wonder how you could come to that conclusion. And then from Stan, who I admired tremendously already at that time, it always amazes me how careful basic laboratory scientists are to have controls in animal experiments. But once they start working on patients, the control disappears out of the window, and we are left with bad treatment for years. I was disappointed, and I was very worried. Because in my view, the study had given some important information. First, that it was possible to put cells into the human putamen without adverse effects. And second, that we could detect some minor changes using our test battery. But would it be possible to continue with clinical transplantation, despite the fact that the recommendations of the meeting was to continue with animal experiments for the next 10, 15 years. That night I shared hotel room with Anders Björklund, my colleague. We had done a lot of studies during the 70s and 80s. This is an early photograph from Paris when he had a lecture tour in 1974. And we shared hotel room, and during the night we discussed this arguments for continuing with human fetal tissue or with cell transplantation, and we decided, I remember it very well, that we should continue with the cell transplantation program with human fetal tissue, despite the resistance of the scientific and clinical community. What we did then as one step, and a very important step, was a meeting with Richard Frakowiak and David Marsden in London. And the question at that meeting, which was held in June 1986, was, would the available methods have the resolution and sensitivity so it would be possible to detect surviving dopaminergic growth after transplantation in a patient's brain? And this had never been done. No one knew if that would be possible, but after 2 hours of discussion, we came to the conclusion that it might be possible using fluorodopa and PET scanning to detect a surviving dopaminergic growth. So in September 1987, I went to, together with my nurse, to London with 2 patients for PET scanning and preoperative PET scanning. And the patients needed a helmet in order to, so that there would be no movements during the PET scanning. And then also the patient had to lie down several hours during the PET scanning without having taken anti-Parkinsonian medication. And this was, of course, extremely tough for the patients, and they were really heroes. This shows the photograph when we have completed Nico Lenders, who had completed the first PET scanning, and everyone was very happy. Richard Frakovic, who you can see to the left, he was opening a bottle of champagne, and we all cheered and were very happy about this successful scanning. Unfortunately, we lost most of the data during the night due to a computer failure, so Richard became furious. Oops. An important step in the clinical translation was this work which we had together with Patrick Brundin, and which was included in his thesis, where we could show that we could get survival of dopaminergic neurons from human fetuses in rat brain. They could reinnervate the striatum. They could also ameliorate behavioral deficits after intrastriatal transplantation in dopamine-denervated rats. So we went ahead with the first transplantations on November 10 and December 8, 1987, in 2 patients. We identified the ventral mesencephalon, made a cell suspension, and which was implanted into the striatum of 2 patients unilaterally. And here you can see D-Day, the first transplantations we did with human fetal tissue. On the left, you can see Patrick Brundin with clothes suitable for dissecting the tissue. Anders Björklund is checking the viability of the cells. And then from the surgery room, Stig Renkrona is putting in the tissue, and also Håkan Widner, who was responsible for the immunosuppression, is present. Of course, this was a major event for us, and we were very, very excited about what was going to happen. And what we had decided was that we should not reveal anything during the first 6 months. Patients were monitored very carefully. We had a PET scanning at 6 months to see if growths had survived or not. And then I was going to present the data on an international symposium on Parkinson's disease in Jerusalem in June 1988. And the meeting approached, the media interest was very, very high. But unfortunately, what we saw was only minor improvement, and there was no detectable change in fluorodopa PET, even if we later found that there was a small dopaminergic growth on autopsy 21 years later in the first patient. So I was standing there. The media interest was very high. There was a film crew from the BBC, so my presentation showing now, once again, in principle, lack of improvement. So that presentation was filmed, and I was, of course, very disappointed once again. But this was not the time to give up. And I remember a quotation from Winston Churchill saying that success consists of going from failure to failure without loss of enthusiasm. I think that was perfect at this moment. But we had to improve the transplantation procedure, and Patrick Brundin found in his preclinical studies that the size of the implantation instrument was important. And we also realized that we had to have more implantation sites in the putamen in order to cover the entire structure. So therefore we went ahead with transplantation in 2 more patients in April and May 1989. And I remember that summer because I was evaluating the patients once a week clinically, and then once a month with an L-DOPA test. And after 3 months in patient number 3, one could clearly notice that there was an improvement in his clinical condition. His mobility on the side of the body, contralateral to growth, was faster, rigidity was less. His condition in the morning before the first L-DOPA dose was improved, and also the L-DOPA dose, if in the test, had a longer effect. So after 5 months, we decided that we should see whether this improvement was due to a surviving dopaminergic growth. And we decided to perform a PET scan. And this time, Anders and I, together with the patient, we went to London. And I remember this, that already at the time of the scanning, when we were sitting there looking at the computer, there was evidence that that there was a surviving growth. And I remember how excited I was. Would it really be possible? I didn't believe that it was true. And when I came home to my wife, and she asked me how was it, how did it go? And I said that, well, I didn't know, maybe I didn't. But after a few days, it was confirmed that there was actually a surviving growth in the putamen. And this finding that it is possible to put neurons into the adult human brain, a brain with a chronic neurodegenerative disorder, and get survival of these cells, and that they can actually influence the function of the host brain, that was the most exciting finding during my entire scientific career. And of course, this also, when our paper was published in Science in 1990, it created an enormous media interest, and it was on CNN. There were many, both national and international papers published reporting of this finding. This is our more local paper, Lund Scientists Succeeded. This is more like some kind of Hamlet version of the story. And then also there were reports in Wall Street Journal, New York Times, Washington Post. Since then, there has been 4 major milestones on the journey, on my scientific journey. And the first one is that growth can survive, that they can release dopamine, and that they could, in some patients, be associated with major clinical improvement despite an ongoing disease process. Also, especially after the negative sham surgery control trials, to demonstrate that dopaminergic denervation pattern outside grafted areas determine the functional outcome after transplantation. The finding that Lewy bodies can be present in a small fraction of grafted cells more than a decade after transplantation, which has triggered a completely new research field in Parkinson's disease. And finally, that serotonergic neurons in the graft are important for the adverse effects that we and several others reported after transplantation, the graft-induced dyskinesias. And I just want to mention one of these milestones, because it was on one of the occasions where Peter Hagel, who was then my PhD student, he's now a professor, and we went with 2 patients for PET scanning in London. And then Paola Piccini told us that she had a colleague who had been able to monitor and quantify dopamine release in vivo in a normal subject who had been playing a video game, and do that with PET scanning. And the method is that you use raclopride as a tracer. It binds to dopamine D2 receptors, but it is displaced by endogenous dopamine. So high binding indicates low dopamine release, and low binding, high dopamine release. And of course, immediately this triggered an idea that would it be possible to quantify dopamine release from grafted dopaminergic neurons? So we planned for this study. We had a quite perfect patient, a unique patient for this purpose, who had been grafted only on one side of the brain, and the other side could then be used as a control. I must admit that I was not very optimistic. I was excited, but I was not very optimistic. I didn't think it would work. But the patient was very enthusiastic. He had done very, very well after transplantation and been able to stop L-DOPA medication. So this patient and I, we went to London. We had dinner in a nice restaurant after 10 years after his transplantation. Before transplantation, he could hardly move without L-DOPA. Now he hadn't taken L-DOPA for many years. So we did the PET scanning, one scan with saline, one scan with amphetamine to look at the drug-induced dopamine release from the grafts. And then we went home. And I didn't hear anything from Paula, and I was absolutely convinced that it had failed. So after a couple of weeks, I called Paula and asked what happened, and she told me everything went exactly as predicted. It was the ideal scenario, which means that the patient in the fluorodopa scan, he had a normal fluorodopa uptake, whereas with the raclopride, both with placebo and he had on the grafted side, similar to a normal subject. On the non-grafted side, there was a high binding, which indicates that there was very little dopamine. And then you could, by using amphetamine, you could release dopamine and quantify that. Nothing happened on the non-grafted side. So in this patient with a major clinical improvement, the graft had also restored fluorodopa uptake as a measure of dopaminergic innervation and dopamine release to normal levels. And our paper was directly published in Nature Neuroscience, and we even got this cover on the issue. Yesterday, where I was unfortunately not able to participate, you heard about the current status of grafting and also with fetal cells, and that there are two sham surgery control studies which have not shown any significant clinical benefit. And I will not discuss that here, but I would just want to mention to you what I think are the best evidence from the open label trials that this strategy may work. And these are two patients who have been followed, and they were selected in London and have been followed in London. And this patient, he was diagnosed in 1983. He was grafted bilaterally in the stratum in 1993 and 1994. And 4 years after transplantation, he could withdraw his L-DOPA medication, dopaminergic medication, completely. This patient was diagnosed in 1985. He was grafted bilaterally in 1996, and also during the 5th postoperative year, he could remove all his dopaminergic medication. And there are 2 points I want to make. One point is that at 16 and 13 years after transplantation, 26 and 24 years after diagnosis, and about 10 years after withdrawal of L-DOPA medication, they have a UPDRS motor score around 10. And gradually, their condition or their fluorodopa uptake has become normal, and they also have a normal dopamine release in the stratum, in the putamen. What I think one can conclude from the cell transplantation field in Parkinson's disease is that there has been a steady scientific progress in this field since 1985. There is proof of principle that neuronal replacement can work in the diseased human brain. Grafts can re-innervate denervated areas, they can become functionally integrated, they can release transmitter, and they can restore function in the diseased 50, 60 years old patient's brain. But as I'm sure you heard yesterday also, current cell transplantation procedures do not provide clinically competitive treatment. So why do I think that we are living in an extremely exciting time now for cell therapy research? Well, now we know that neurons for transplantation can be generated from different sources of stem cells and reprogrammed cells. You heard that yesterday. Not just dopaminergic neurons, but also other subtype-specific neurons. And also that we have neural stem cells in our brain, both in the normal and in the diseased brain. And finally, that there is now also evidence that you can generate neurons directly from glial cells and other cells in vivo in the brain by in vivo reprogramming. Yesterday you heard that dopaminergic neurons and also other types of neurons which may be important for Parkinson's and other diseases. You can get dopaminergic neurons from neural stem cells. You can get them from pluripotent cells, generated from blastocysts, human embryonic stem cells, or fibroblasts. And you can also get dopamine neurons directly from fibroblasts, and they can be used for transplantation. But we also have neural stem cells in our adult brains, and new neurons are continuously generated in these areas. These are the neural stem cells around the ventricle, in the lateral ventricle, and then we have also in the dentate gyrus, giving rise to granule cells and important for learning and memory. And we showed several years ago in rodents that these neural stem cells, they can respond to an injury, to a disease, by, for example, in stroke, where there is a big lesion in the striatum and the overlying cortex, they start to proliferate, they form new neurons, neuroblasts, which migrate towards the injury and then differentiate to mature neurons. And this potential self-repair mechanism was recently, the interest was recently stimulated a lot by the finding from Jonas Frisen's group using carbon-14 dating that actually in the adult human brain, there is in the subventricular zone, there is a proliferation of cells, of neural stem cells, and they give rise to neuroblasts which enter the striatum where they differentiate to striatal neurons. And interestingly, this mechanism is suppressed in patients with Huntington's disease. And finally, and this is of course very far from the clinic, that we know now that glial cells can be directly reprogrammed to functional neurons in vivo in the adult rodent brain. And what scientists have done is to use a viral vector expressing a transcription factor that has been injected into the brain and been able to convert astrocytes to functional neurons. And this has also in vitro been shown to be able to convert a human glial cells, an astrocyte, to a functional neurons. What will come out of this, we don't know, but we now have many, many tools to continue to develop this field, which makes me extremely excited. What I wanted to say at the end is that I hope I have illustrated for you that there is no fast track for cell therapy in this type of disorders. But with the rapidly increasing knowledge about brain plasticity and cell plasticity, I'm convinced that we will be able to develop clinically competitive cell therapies in the future. But finally, if you ask me, how far have we reached? Where are you now on this development? How far have you reached? I would like to answer by using another quotation from Winston Churchill. I think we can say that this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. The journey I've been telling you about has not been possible without a lot of excellent scientists, and I want to thank all of them for having contributed to this journey. Many of them are my very close personal friends also since many years. So thank you all very much.
I just want to mention that Dr. Jankovic showed a picture of the founders of the society, and all but one of them are in the audience today, and it must be very gratifying to see how far this field and our society has come these last 30 years. Congratulations to our junior awardees and to Dr. Jankovic and Lindvall for fantastic contributions this morning, and that will conclude this morning's session.